This is part 2 on communities for a cure. In this part I will be talking about technology, the technology layer enabling these platforms. So just to review, when a patient has a problem, it is my problem. As they aggregate themselves into a group, it becomes our problem. This can be through a blog or other aggregations. However, when the group then gets an advocate or a communicator, it becomes their problem. The advocate can act as a business bridge, reaching out to others who may be interested in speaking to the group. This allows very interesting things to happen where the information within the group becomes valuable to others and allows some sustainable business models. Here's the basic business model. The advocate and patient have a interactive relationship where the advocate begins to understand the patient. Others come to the advocate, researchers, etc., asking for particular patients for a study. The advocate sends a message to the patient saying, "You've been asked to participate in a study. If you'd like to, please contact the researcher directly." This is voluntary participation, protecting the patient's confidentiality at all times. For that transaction, the researcher pays the advocate, and that allows a sustainable business model. There are 3 major steps to any community. There's enrollment, which is in this case self-enrollment and viral engagement. Why would you want to be involved? What kinds of things are valuable to you as a participant? And then finally, repeated communication where the advocate and the participant get to know each other at increasing, or get to know about the patients in increasingly granular ways. So when we talk about technology, data elements have multiple parts to them. You want to know who's giving data, what data are they giving, where are they giving it, how are they giving it? Is it over a snail mail? Is it email? Is it text mail? And then in what order are they giving these data elements? This is a outline of the platform that enables the technology. So you can see at the very top of this the data, workflow, and output requirements. These are effectively the data elements are defined and then poured into the middle portion, the factory, which then spits out solutions. On the bottom you'll see a couple of interesting things. There's a reporting, a business rules layer, transformation and translation layers. I'll cover these a little bit further, but in general the reporting layer allows data to become information. This information can be presented in a way through the presentation layer that is familiar to the receiver. So whether you're a patient, a nurse, a physician, an administrator, you may want to see a different presentation layer. The business rules layer effectively translates data into other actions for the translation layer. So I'll go through some of these. HL7, by the way, is the common language that medical platforms communicate by. These platforms can both in and out data to other applications. So from a very macro perspective, we have a form factory. Workflow data elements are defined. The form engine publishes solutions which allow action-driven responses. Because there's no programming, design to data capture takes approximately 6 to 8 weeks. So if one were to dig down into the database, you can see very granular data about all the participants. These do not necessarily have to call out a name or specific identifiers, but simply a way to repeatedly communicate with the participant. We do, however, begin to understand how long you've had the disease, what drugs you're on, what comorbidities you may have had, who else is in your ecosystem, many data elements about each of the participants. Here's an example of a business rules layer. You might not think of it as this, but a business rules layer can act as a translation layer where the platform can be in English or Spanish or Chinese for that matter. Business rules layers may also be, I've put in a bunch of data, and that data is now pushed out as a computed new piece of information. Messaging allows repeated, automated, and custom communication with the participants within the community. So in this case, a customized message is being sent to a particular subset of the database that is now personalized. So not every member of the community may get this message. Only men who are over 65, who've had less than 1 year diagnosis of Parkinson's, would receive this message asking them if they might want to be in a trial. You also want to know about your community at all times. Who's responding by paper? Who's responding by email? Who have we not heard from? Who do we need to reach out to again? Unfortunately, we all forget things. Reminders are part of the database. So there may be a query and ask of a patient or other participant of the database for a particular piece of information. If they forget, a reminder is sent. So this could be a physician who was supposed to give information and has not done so within a period of time. This could be a patient who is recording their weight on a regular basis. Joe Smith, we have not received your weight in the last 24 hours. Could you please remember to do so? Any participant within this community can be messaged and reminded to participate and put their data in. I would also note that reminders can be escalated. So for instance, if a patient has not put data in over a period of days, there may be an identified caregiver who would then be notified and reminded to check on this patient. Reconciliation is important so that people do not have duplicate entry. There are robust back-end reconciliation engines for this as well. For data to become information, there has to be an active reporting layer. So patients, nurses, doctors, administrators all respond and are all interested in data in different ways. So as you look at this data, which can be reported in real time, pushed out rather than queried, this is data about the large aggregate of the population. But you may want to look at patient against themselves over time. You may want to look at patient against their peer group. You may want to look at a particular physician practice or the entirety of the aggregate. In each case, data needs to be presented in a way that is acceptable to the receiver. Here's another example of reporting. In this case, this is a patient in an individual physician practice, and we're looking at outcomes-based research of that patient. I didn't want to leave you with the sense that these are strictly self-reported registries. There is an opportunity for others to contribute data along the way. So here's an example of a physician data entry point. So this is information being provided by a physician, but it is in a way that is customized, familiar to a physician as opposed to a patient. Nursing information may have a different context, a different way of putting information, and this was in fact customized around nursing information. And then finally, patient information has to be entered in their own way as well, where it's familiar to that patient. I would note that the platform is compatible with HealthVault, and although this points out textual data, one could easily put in device data through Bluetooth that would be integrated through HealthVault. So you might measure blood pressure or weight. Other devices can provide, glucometers, for example, can provide additional automated data into the platforms. So what we're really talking about is an evolution from paper to digital acquisition of data. This could be through desktop, laptop, PDA. It could be text messaging through your phone, email, or simply conventional mail. There are entry points. We've focused on patients with the self-reported registries, but there are entry points for nurses and physicians as well that then provide an information stream. Data becomes information, which drives actions, which may further influence data gathering at a later point. So this information stream, this continuity becomes very important. I would note that the NARCOM's Communities for a Cure has shown significant value to its participants. There's been tremendous stickiness. If you enrolled 10 years ago, there's about a 50% chance that you are going to continue to use this platform. If you enrolled 3 years ago, there's a 90% chance that you're still using it, that you're finding value in reporting information about yourself for others to use and for you to use in your own care moving forward. I would also mention that patients care about an ecosystem. They care much more about the entirety of things that matter to sustain their wellness, not just healthcare records. There's a lot of emphasis now on aggregating healthcare records, but many other factors are important to participants in these communities. So for example, several years ago, it was called out that a separate registry was devised for caregivers, as the caregiver of someone with a chronic illness themselves suffers, the patient also suffers. So and these are specific questions for the caregiver. How are you dealing with your significant other's illness? Just as an example here, the NARCOMS community wanted to know, was there a relationship between MS and smoking? So they were able to get 2,000 respondents within 24 hours, 5,000 within 2 weeks, to help them understand this question of the relationship of MS and smoking. I would not say that this is the only answer for science moving forward, but it is certainly a piece of it. The NARCOMS community has been able to help provide over 30 peer-reviewed articles and 70 abstracts and presentations over time.